first thing I do is slide my hands down the lymph nodes, the mandibular lymph nodes, while I'm talking to the client. Just a very kind of normal part of my process when before I even open the mouth, before I even, discuss the problem at hand, is I'm feeling the lymph nodes. And then start on the opposite side of the presenting problem. So if a patient comes in and they say, hey doc, there's ulcers, or they seem painful on this side, or maybe there's a fractured tooth, or I noticed this bump. I think a lot of things that we want to do is immediately look at it, right? We're drawn to those things. An important thing to do is to still do a very thorough oral exam everywhere. And how I do that is I start on the opposite side of the problem for a couple of reasons. One is it forces me to appreciate everywhere in the mouth. The other thing is a lot of times if they're presenting for a problem on one side, that's where they're going to be most tender. So if you start on that side and you're poking and prodding around in there, and their owner has already opened their mouth 14 times that day to look at the same problem, and they're going to be uncomfortable and maybe a little bit resistant to that. So start on the opposite side of the mouth, work your way to the side of the affected problem. That way you're getting a really good view of everywhere in the mouth. Final thing is, or one of the final things is, open up. I think a lot of times where these dogs and cats have their mouths clenched closed and we just, say, okay, well, certainly there's nothing going on. A really important part of an oral exam is that final thing, that last, 30 seconds before you're like, okay, I know what's going on here, is you really have to open that mouth up as much as they'll allow you to. And I realize in some cases that's not always easy to do, but you're going to miss a lot of lesions if you don't do that. So here's an example of these palatal ulcerations. This dog actually, probably not a primary condition in this particular patient, and had IBD and had regular regurgitation. And I believe these are ulcerations secondary to that constant regurg. Here's a kitty that presented, been treated for quite a period of time for a potential abscess, dental abscess. And I just opened up her mouth there, and clearly there was a really erosive squame, probably tonsillar in origin, working its way to the soft palate. Not a great prognosis for this guy. And then here's one that's pretty gnarly. This dog presented for weight loss, difficulty eating. We couldn't find a problem really, oddly enough. And so this dog would absolutely not tolerate you opening its mouth during an awake oral exam. So gave her some sedation, and this is what we found. So it's important to know that a lot of these dogs that are clenching their mouth shut, certainly it could just be that they're not tolerant of that and never will be. Others are because they're guarding something. So it's important that if you're not able to do a thorough exam, but you question if there's something in the mouth, give a little sedation and look a little further. Check under the tongue. All right, this is a huge one, and one that I see with some frequency, especially in cats that are drooling excessively and have maybe chronic weight loss, and they're an older cat, and we say, wow, their teeth are really gross. Well, that's true. A lot of cats do, obviously have worsening dental disease as they age, but we have to understand that's typically chronic. So it's uncommon that I see an old cat presenting for all of a sudden its teeth, tipped over that point where they're the problem, especially if there's a lot of drooling involved, bleeding, their front paws are a little bit wet. Usually that's not going to be the teeth. So in this case, obviously a sublingual squame working towards the base of the tongue in a cat. This was a dog that presented to the ER for oral hemorrhage, and there was concern for a rostromandibular fracture, but the fracture seemed relatively stable. The dog was still bleeding quite significantly, and on closer inspection, he had quite a large laceration in the lingual frenulum. So classic, right? Doc, my dog broke its tooth, and I have no idea how it happened, right? So that's usually how it goes, and it's, not just big dogs, these little guys too. And our two most common fracture cases are uncomplicated crown fractures and complicated crown fractures. We'll start with the uncomplicated version, and basically that's a fracture of the enamel or the enamel and the dentin. So the hard structures, the outer structures of the tooth. No pulp exposure is seen in these cases. And some of these guys, if it's a more chronic type of case, you may see a discoloration centrally. Sometimes that's repaired in that process, but there's no actual exposure into the central portion of the tooth. Often it's an incidental finding on a thorough physical exam. A lot of times that's where I'm getting some referrals for these fractured teeth, is a veterinarian doing a very thorough exam and finding a fractured tooth, even though the owner was unaware. They can be painful and sensitive in the acute phase. And I would say even sometimes more in the chronic phases in some cases, but when they initially do it, so the owner notices, right, boom, chip fracture, they gave them the ham hock, and then all of a sudden there's this fracture. They can be painful, certainly briefly. We'll talk about why that is in a little bit. And the complicated crown fracture, right? That's the one where we see that central red dot, or maybe even bleeding in a young animal. And that's where that pulp is exposed. So the vital portion of the tooth where the blood vessel and the nerve live. If not addressed within the first 48 hours, there's a high likelihood of tooth death. I think it's uncommon we see them in that first 48-hour period sometimes, or at least not definitively in that first 48-hour period, right? So we talk to the owner and they say, hey, you know, it just happened yesterday, and then you quiz them a little bit more and there's like, oh, well, I haven't really looked in their mouth in a month and a half. And so, you know, the timeline can be a little tricky. So a quick review on anatomy, everyone's favorite subject. So dental anatomy, I will give a very brief view of this. I'm sure some of this is pretty repetitive for some people here, but of course the tooth has this outer, very hard structure, the enamel. Inside of that is dentin. An interesting thing to note about the enamel in dogs, it's actually thinner than in people. So if we can imagine us chewing on some of these antlers and things like that, and you can imagine you'd fracture a tooth. The reality is the enamel in dogs, that outer structure, is actually a little more thin than it is in humans. So if we can fracture a tooth on something, we can certainly believe that they would. The dentin is that hard inner structure. There's alveolar bone, and then we are surrounded by a periodontal ligament, and this central portion here is where all the vitality of the tooth is. So that's where the blood vessel is, that's where the nerve is, and then we have this apex here, which is really an apical delta. So there's little tributaries of small vessels and nerves leading into that central pulp chamber. The dentin structure is here. So it's little tiny tubules. So it's not a really truly uniform, firm structure. In fact, there's surrounding mineralization, and there's these small tubules running through it. And those tubules feed into that central pulp chamber. Small cells that are dentin forming cells actually put projections out into those dentin tubules. And so, you know, when that is exposed, not only are there actually extensions of nerves exposed, but it's also a small tributary or highway to that central pulp, which is why we need to consider an uncomplicated fracture potentially an issue. It's not something, you know, that is always a wait and see type of issue. We can see pathology with that. So how do we treat these uncomplicated crown fractures? Take an x-ray. So that's the first thing. Take that radiograph, no matter what. Even if you say, hey, I'm probing around this tooth, there's no central pulp, I'm not dropping in anywhere, I'm pretty sure this is uncomplicated fracture, you should really take an x-ray. The reason that is because of those dentin tubules we just talked about. There's these small highways to that central pulp area where, if bacteria make their way that direction, can certainly cause tooth death and periapical disease. You should, from a treatment standpoint, you should smooth those teeth over. Okay, so use a fine diamond burr or a Dura White stone burr on a high-speed handpiece. We're going to try to smooth over those edges of enamel and expose dentin. The reason you do that is for a couple reasons. One is, if you have these sharp edges, there's chance for trauma. So that's not uncommon. I see even cases of either acute fractures that may not be exposed and then they're uncomplicated, or these abrasive type of long-term uncomplicated fractures where these canines are worn into sharp points, causing lacerations to the underside of the tongue. So it's important to smooth over those edges of that enamel and dentin with care, and understanding that there is a vital portion living underneath there. You don't want to go too far because you may expose that pulp, and then we're dealing with a complicated fracture. You're going to use a bonding with light cured unfilled resin, which is basically something that's going to seal up those dentin tubules. And in the end, this is that same tooth after we've done an odontoplasty and a bonding. So it's got a nice finish to it. There's no sharp edges. We're using our probe to make sure we're not finding any edges on that enamel. And these are some of the objects we're going to use, or some of the tools we use. So here's an unfilled resin. That's a 3M product. There's a fine diamond burr there. There is a light there that is going to cure that resin. So treatment of the complicated crown fracture. So we've all seen this, right? So that PM4 with that fracture on that cusp. And root canal therapy should be kind of what our gold standard is for care of complicated crown fractures. It's important that the patient's a good candidate, though. So there shouldn't be a root component to that fracture. So we've seen a lot of these slab fractures that go underneath that gingival margin. Those are not fantastic cases for restoration, mostly because there's always going to be a pseudo pocket there. So there's going to be a pocket where no matter what, even if you do a great root canal, there's a chance that that tooth fails because of periodontal disease. So a pocket and a place that basically the dog can't floss. So there shouldn't be any overt root resorption or extensive periapical disease on the x-ray. So I'm hoping that that root system has a relatively defined periodontal ligament, and that there isn't extensive resorption or death in the root system, because that doesn't make for a great candidate for a root canal. And then the canal itself should be relatively open. So as an animal ages, as you know, that canal will narrow. And as it does so, sometimes it becomes stenotic in certain areas. There's sometimes these enamel pearls or things like, or dentin pearls that are inside of those pulp chambers. And if that's the case, we can't really instrument past them. And what I mean by instrumentation is, here's a tooth, that same tooth actually, that is being prepared for a root canal. So we're instrumenting that tooth with hand files. So each one of those 3 roots is individually being prepared. And if we can't pass a file because there's an obstruction, that doesn't make a fantastic candidate for a root canal and potential failure. In a good candidate, the root canal is, I would say, upwards of 95% successful. This decreases with chronicity. So if this is an old fracture where there's evidence of infection or resorption in the root system, we're going to drop more to 80–85%. Some are just not a candidate at all, and certainly we wouldn't recommend that at that point. A big portion of a root canal is we need to make sure the owner's educated as to what a root canal is. Luckily, a lot of the clients we talk to have had a root canal themselves, and so have some idea of exactly what we're talking about. But the expectations are important. So we need to understand that when we're doing a root canal, it's not just a once and done. There is some follow-up with that. So yearly dental x-rays are recommended to make sure that we are not seeing any evidence of continued periapical disease. And also, we're just making sure that there's not failure of those restorations at the end. This shouldn't be a major issue, and kind of my client education aspect of this is when I'm talking about root canals and if this is a limiting factor, I do try to tell them that there should be an understanding that no matter what, our recommendation is yearly anesthetic cleanings. So we're not going to be putting your patient under anesthesia for anything other than what we would already be doing for yearly cleanings. We're just making sure we're taking these follow-up x-rays and evaluating that tooth under the same anesthetic event. Oftentimes people are understanding of that. But sometimes if it's a client who's like, hey, listen, I'm never coming back for follow-up, may not be the best case for a root canal. So this is what a root canal looks like, that exact same tooth actually, after we have removed the pulp chamber there. So that vital structure within the tooth, or once vital structure, is removed. We disinfect those canals, and then we file them to a point where they are relatively uniform, and then fill them with an inert type of material. They get restorations on the 2 access points and the fracture site, just like the same type of restorations you would get for a cavity or a filling. And this is that tooth after treatment. So we preserve the structure of the tooth. It's a functional chewing tooth in a young dog. If they can keep it, that's fantastic. And so this was a very successful case of a root canal. So the other treatment option is extraction, right? And I think this is what we see more commonly, and certainly historically has been the treatment of choice. I would, consider that we should try to change that a little bit, and in the hope that, we make root canal and saving the tooth, especially if it's a functional tooth, more of a priority. But in some cases, that's not an option. So in this case, for sure, that is not an option. It's got a very large segment to it that is a root component. So if we were to remove that root segment, there'd be a large pocket next to that tooth, and it wouldn't be a good root canal. It's considered a salvage procedure. So when I'm talking to someone, I say the success rate is high because I'm removing the problem. Certainly there's a potential for surgical complications, but the mouth, as I think everyone has said at one point, the mouth likes to heal. So in this circumstance, we don't often have surgical complications, but certainly can happen. But it should be avoided in functional dentition in young dogs. So if there's a chance to save the tooth, you should at least advise the client that, hey, this is an option. It allows us to preserve the function of your dog's mouth, and it would be what I recommended. If financially that's not possible or they're not going to follow up, then certainly extraction is the best next bet. The only wrong thing to do is to do nothing. So here's this same tooth. We have obvious periapical disease in both the distal root and the mesial roots as well. So not only did it have a complication associated with that root component, but it also had pretty significant periapical disease. I wouldn't say that this periapical disease in itself would have stopped me from a root canal, although I would have given the owner a little bit of a poorer prognosis, but it would be possible. Another factor that we see here is this canal gets quite stenotic right here, kind of on that mesial root, where we can see right from this pulp chamber, and it gets pretty narrow right there. So instrumenting that tooth might be a little bit challenging. So the emergency fracture, I would say this is infrequent. All right. So I think that every client who presents, it's an emergency fracture, no matter if it's happened 3 years ago or it happened 20 minutes ago. But it's very uncommon that a fracture needs to be treated emergently unless it's a young dog. So if it's a dog that's 18 months old or younger, where the owner wants to preserve the tooth and it was fractured within 48 hours, we can consider this in a true emergency. And that's because a root canal is not an option for young animals who are usually less than 9 months. It's dependent on the breed. So if it's a young dog, if it's a small breed dog, sometimes their teeth have matured and they can receive a root canal. But in this large breed dog, for instance, this is a 9-month-old dog, the apex of this tooth is not yet formed. So it's still one large, pretty much open pulp chamber here into the alveolar bone. There's no stop to this root system. There's no delta feeding in. So if you tried to obturate this, meaning fill it, you would leach all of that material into the outer bone, which would not lead to a successful root canal. So our option instead is a vital pulp therapy. So what we do is our goal is to preserve the actual vitality of that tooth. It'll continue to live. We do an aseptic technique for a vital pulp therapy. So we remove that sharp edge of crown and we, in sterile technique, put in a filling. And this is what it looks like after the fact. So we can see this material right here is plugging that fracture site. That's MTA, which is a substance that is very biocompatible. So it'll actually help form a dentin bridge there. It's not toxic to the pulp. And so it'll allow for basically a new edge to that cusp. And then there's a final composite filling on the end, just like we would do in a root canal. This is that tooth after the fact. Obviously, it's a little blunted, but it will likely survive. We will do recheck x-rays on that tooth either 3 to 6 months from them to make sure that the pulp chamber has continued to narrow. And that will allow us to realize if that tooth is continuing to stay alive. So stomatitis, this is a very broad statement, right? So stomatitis just means inflammation of the mouth and the mucous membranes. It's something that I think we use very casually as the term for feline gingivous stomatitis or feline chronic gingivous stomatitis, but it's a very broad term. So feline chronic gingivous stomatitis, I think we've all had some experience with that. The thought process is there's a potential association with viral respiratory disease in cats, so calicivirus being the one that we most think of, but it is not the causative agent. So it's important to understand that although patients may have respiratory disease, so whether they have herpes virus, calicivirus, does not mean that that is what caused the stomatitis. It is just something that we see in high association with stomatitis. It's thought to be an overabundant reaction to the normal oral bacteria and biofilm in the mouth. So even when there's not significant evidence of calculus or plaque buildup in the mouth, even the smallest amount of bacteria will cause this overabundant reaction in the animal's mouth where they get these ulcerations. Not only along the teeth, that's where it's usually most reactive, and that's because that's the closest association with the biofilm, but also towards the back of the mouth and in the caudal pharyngeal region, especially in cats. CUPS, so chronic ulcerative periodontal stomatitis, which is, I believe now, currently being changed to canine chronic ulcerative stomatitis. That will change again by the time this PowerPoint is over. I'm sure it's in constant flux, but it's basically an ulcerative stomatitis in canines. This is a little more easy to define, I think, than some of the gingiva stomatitis cases, because there's oftentimes very classic kissing lesions in dogs. So the tongue or the oral mucosa that are most closely associated with the teeth and are in direct contact are most often the areas with ulceration, whereas cats, they don't necessarily present with as classic of a case sometimes. It's oftentimes very generalized and not as focused as CUPS cases in dogs. So pathogenesis, who the heck knows? The thought process, like we said, is that there is a bacterial component to this. The reason we think that is because of how closely associated the inflammation is with the teeth, where the biofilm most likely builds up or is most abundant in the mouth. So how do these cases present? Certainly they're drooling quite a bit. Halitosis is the big one. So an owner will say, you know, this cat has always had bad breath, and it's a 1.5-year-old cat that they've gotten from the shelter and, you know, otherwise healthy, happy, but, you know, they say, man, its breath always stinks. They have a preference for soft diets, although this is not universal. There's plenty of stomatitis cats walking around that are still eating hard kibble, whether they're actually using their teeth or just swallowing it. A reluctance to groom. So some of these cats who present middle-aged to older don't look too thrifty, maybe a poor hair coat. They haven't been grooming a ton because their mouth hurts. Reduced appetite, but like I said, that's not always. We see some of these cats coming in eating quite well, which I like to see. That makes for a good surgical candidate for sure. And oftentimes these guys have an initial response to dental cleaning or antibiotic therapy. And the reason that is because if we're reducing the bacterial content in the mouth, whether that's with a drug like an antibiotic or with reducing that biofilm or plaque, then we are going to be improving that overabundant response. Sometimes they have a poor body condition. Other times there's a concurrent upper respiratory infection like we talked about. So here's some cases of feline chronic gingivostomatitis. So here's a very bright highlighter red line around all the gum tissue here. Pretty classic for a young cat to have such significant abundant inflammation. We're probably looking at stomatitis. Here's caudal erythema in the back of this guy's mouth, associated with the palatal-glossal folds. That's pretty much telltale. So if you're opening up a cat's mouth and you're like, man, it does have some gingivitis, I'm not entirely sure if this is perio or if this is stomatitis. If you open that mouth up and you see inflammation in that soft palate region or back kind of in the palatal-glossal region, you're going to say, okay, well, I've pretty much confirmed my diagnosis of stomatitis here. So here's chronic ulcerative periodontal stomatitis. This is CUPS dog, right? So just nasty inflammation all towards the rostrum aspect of this guy's mouth. So this is just in every tooth that is going to be closely associated with the mucosa along the superior labial margin here is in contact with these incisors and the canines. And so that's pretty classic depigmentation of this guy's lips with ulceration. Here's these really red ulcers associated directly with that big canine tooth. That's where we see it a lot, the canine tooth and also the carnasial tooth, like in this case, some severe ulcerations wherever that mucosa butts against the tooth. And this is something to always look for, especially if you're not entirely sure if you're dealing with cups. Look at the tongue. So oftentimes the rim of the tongue will be completely devoid of taste buds, and there'll be kind of a sheen of ulceration. And that is oftentimes associated with cups. So the first step, I think dental cleaning and extensive home care routine is something you can offer. I will say it fails most often. It can be tried initially. It'll reduce the bacterial population. But if someone's really great at home care and they're super dedicated to keeping the teeth in the mouth, certainly home care is a good option with very regular cleaning. So maybe 3 to 6 months, you may be able to preserve some comfort in this animal and reduce the inflammation and reaction. The real treatment, or at least from my standpoint, as a surgical treatment, is full mouth extractions. Okay, and this can be challenging due to anthropomorphism, right? So everyone is going to put that animal in their own shoes and say, man, if I can't imagine having a single tooth extracted, let alone all of them. I will say these animals do great. I have seen enough of them that I have complete confidence in saying I don't think their quality of life is poor because of having extractions performed. I think that maybe it's a difficult thing for an owner most of the time, and certainly there's a financial component and something to consider. But the first step is to remove the place where this bacteria likes to build up. And then cosmesis, right? So some people are just like, hey, I don't want my dog or cat to look like they have no teeth. I don't really think that's a major issue in cats. I think that their changes are minimal. Cosmetically, dogs can get glossoptosis, so their tongue will hang, they'll look a little goofy. Usually it's side dependent, so oftentimes you'll notice a dog will only stick out its tongue to one side. That isn't uncommon, although it's not something I would consider a medical concern, which is what I tell people. More often it's just associated with their appearance. So refractory stomatitis, this is something we all hate. This is the frustrating portion of stomatitis. And that's where inflammation and clinical signs are made after extraction. So we're going to take confirmatory x-rays after we remove all of the teeth. So we're going to have those radiographs to prove no root systems are left. If you leave a root, there's still a chance of reaction in stomatitis cases. You got to get all of those out. Recheck in 2 and 4 weeks post-op. If they still have significant inflammation at that point, you need to consider that case potentially refractory, meaning regardless of extractions, it was not entirely successful, and we need to consider long-term drug management. Some of our options are steroids. We all know the side effects of long-term use of steroids, although we're going to try to reduce that to a pretty low dose of steroids, maybe every other day, maybe a very small dose once daily. Cyclosporin is a relatively good option, although we need to consider some aspects of kidney disease, anemia, and that can limit those. Interferon omega was something used quite a bit. I have not used it personally. It is very expensive and difficult to get in America at the moment, although there is some relatively high success with that. Low-dose doxycycline is also something to consider. You start about 2 mg per kg for the first month or so, and then drop to 1 mg per kg indefinitely. And really that's for both the antibiotic component, so you're reducing bacterial content within the mouth. You're also using it for its anti-inflammatory properties. And a big thing I want to note is avoid medical management prior to extractions. So when we're seeing these cases and they have already underwent kind of extensive treatment with repeated injections of convenia, depot, things of that nature, the teeth are still in the mouth, they maybe had 1 cleaning, a few selective extractions, It's more often these cases that are teeter-tottering on medical management prior to extractions are the cases that I see become refractory. There's no study to prove that. It's just something that I have personally seen, and I think something that can be a little bit frustrating when we get the cases, only because I'm pretty certain at that point that surgical options are maybe not going to be curative. So malocclusions, I think a lot of times people think that, they see the pictures of dogs with braces and they say, okay, well, I think I'd like to fix these teeth in my dog. They're crooked. That's usually not what's necessary. So one thing to kind of classify malocclusions, skeletal malocclusions, right? And that is a discrepancy between the length of the upper and lower jaws, so the maxilla and mandibles, and it's often inherited. I will say use caution when saying that to somebody because there's no study that proved that. There are some old breeding studies from a long, long time ago where they crossed brachiocephalics and they found that brachiocephalics did have a genetic component because it was predictable in offspring. There are some human studies where they're using identical twins and both of them have the same malocclusion, meaning that there must have been a genetic code for that malocclusion. So it's a high likelihood skeletal malocclusions are genetic in nature, although we cannot prove that. So active movement of the teeth with braces or orthodontic appliances are usually not a good option for these cases because there's a discrepancy in the actual jaw length. So unless you're able to move the actual jaw, which is unlikely with orthodontic movement, usually that's only moving individual teeth, it's not a great option for these cases. The class 2 malocclusion, I think, is far and above what we're seeing most often in young animals. And what we do in these cases is often interceptive orthodontics. So our goal is when we see these young cases come in with these baby teeth that are kind of these lower canines that are causing palatal trauma to these upper area of the palatal aspect of these maxillary canine teeth, is we want to remove those teeth. The reason we do is not only because it's causing trauma. I think that's a major portion, but the other thing is if there is some potential growth in this lower jaw, it is being inhibited by the physical barrier that is formed by that inappropriate interlock. So by removing these deciduous canine teeth, we're allowing for the potential of that lower jaw to continue growing. Because just like the legs, the jaws have growth spurts, right? So the maxilla and mandibles don't always grow in unison. So it allows us to give that lower jaw a chance to catch up and potentially have a more normal adult occlusion. Treatment options for these guys long-term, so this is in the adult tooth, is crown reduction and vital pulp therapy. So what we're going to do is the same thing as what we did on that dog with the emergency fracture. Except we're going to do it ourselves. We're going to manually reduce those canine teeth to about the level of the incisors and put these fillings on them. It allows that tooth to remain in the mouth as a functional member. It just won't cause the trauma that it previously did. We would address those palatal defects if necessary, and we should avoid extraction of those lower canine teeth unless absolutely necessary in severe cases, just because they do take up such a large portion of that lower mandibular bone. And one thing we should note is goal should be comfort and function, not aesthetics, right? So we're not moving teeth just to please the owner. We're doing it because we feel the dog is uncomfortable. So a class 3 malocclusion, right? This is the brachiocephalic dog. Oftentimes treatment is not necessary in these guys unless there's inappropriate contact from those maxillary incisors on the lingual aspect of those lower incisor teeth. So oftentimes I will see little divots or ulcerations associated with that mucosa there from those incisor teeth of those canines. And in those cases, we may consider either selective extractions or potentially smoothing over the sharp cusps of those incisors. And then the class 4 malocclusion. So this is an asymmetrical malocclusion. This is that classic wry mouth in a dog, or, that's the old saying. And what that is basically one side of the jaw is growing at a different rate as the other side. Oftentimes this is associated with a traumatic event during a growth stage. Potentially it's congenital or inherited, but most often I see these cases as traumatic. Here's a dog we can see with a very normal set of maxillary incisors on one side, and then these rotating eyes on the other side, and a much shortened incisive region here. And that's because this dog actually had trauma from a housemate at a young age, and it presented with this malocclusion because of that. So class 1 malocclusions, this is where we consider potential orthodontic movement where there's malpositioning of single teeth with normal rostrocaudal relationship of the dental arches. So the length of the jaw is appropriate, the teeth are just in the wrong position. So in these circumstances, we can consider these cases that have, you know, those lower canine teeth are kind of a little more palatal than we'd like them. They're not fitting into that nice triad here. They're kind of a little bit more onto that palatal mucosa. We can consider movement with them with acrylic appliances and things of that nature. Here's A and B are before and after of a dog who had class 1 malocclusion of this mandibular canine tooth. So it was poking into the roof of the mouth. We did interceptive extraction of that tooth, and as the adult tooth came in, unfortunately, it still was not in the appropriate position. So this dog got an inclined plane, which is an acrylic appliance on the roof of the mouth that diverged that canine into the appropriate position. Down here is a class 2 malocclusion, a very severe one, where this dog has pretty much a reverse bite. So its canine tooth is on the mandibular canine tooth is on the mesial aspect or the distal aspect of this maxillary canine tooth. And, you know, because of that, it is, you know, interdigitating in the wrong area, although this dog is a very functional normal occlusion. So although it's not normal by the textbooks, it's functional and okay for this dog. So no treatment would really be necessary in that particular case. So the caudal malocclusion in cats, that's something to consider. That's where that upper premolar, fourth premolar is causing contact to the mucosa next to that mandibular first molar tooth. This I see pretty frequently in brachiocephalic cats and with chronicity. So after repeated trauma, that tooth hitting that soft tissue regularly, you can see overgrowth of inflammatory tissue. And it's often bilateral. So my treatment of choice is typically extracting that chewing pair because of that trauma, because no matter what, they're still going to be hitting that area, even if you remove selected teeth, or even if you smooth over teeth. So that's the other option. You smooth over those crowns. But I think chronically that issue is usually not resolved unless you actually, you know, remove that chewing pair. Here's a pyogenic granuloma forming in a cat that I believe was less than a year old. And that's just a really abundant inflammatory lesion. Oftentimes these cats present for concerns for tumor in that area, but it's just secondary to frequent or chronic malocclusion. All right, that's it. I realize I am in the dark at the moment, so I am going to try to move to an area of light. But if you guys have any questions, please let me know.
Dr. Herrmann, we've already got 3 questions on the board, so we're already ready to go. So I will read these to you, and you can tell us, give us your feedback. All right. So Dr. Cromwell asks, if we don't have the light cured resin, is it still advisable to smooth the rough edges of an uncomplicated tooth fracture with a burr, or should we not smooth it if no resin is available to see it?
That's a good question. I would say that I would avoid smoothing that area over unless it's something that's really traumatic. So if we're seeing a tooth that has like a really sharp edge, the animal's already anesthetized, they're getting lingual laceration, things of that nature. When you're smoothing it over with a diamond burr, you are, if there's reparative dentin already in place, so if the body's already tried to patch those tubules, when you're using the diamond burr, you're actually opening up those tubules again. So you're re-exposing that access to that pulp chamber. So I would typically avoid doing that unless you're certain you're just getting enamel, because enamel doesn't have any dentin tubules in it. So I guess in general, I would probably avoid that if you're not going to be able to seal and bond that over with resin, unless there is trauma happening due to laceration and you already have the dog under anesthesia and you say, okay, well, they're not going to be referred. They're not, you know, they're not going to take that second step. Then to provide the animal comfort, certainly that is a risk reward scenario. The other thing is, if you're certain it's just enamel, there's no tubules in enamel, so you can, in theory, smooth that over without absolutely having to bond it. I just think that's a very fine line.
Okay. Next question comes from Dr. Urbanate. She asks, in regards to full mouth extractions, how imperative is it to extract all teeth versus leaving canines and incisors behind? Yeah. Can you get resolution of the disease if you leave those teeth?
Yeah, so that's something that I think we still discuss, as dentists in regards to full mouth extractions. I will say there are cases where I have extracted just caudal dentition, and that is cases where they had true just ulcerations associated only with those back teeth. I would say more often than not, those cases where I have seen people have done selective extractions on caudal dentition come back for continued inflammation in the mouth, ultimately associated with the canine and incisors. So although you can make a stepwise approach to that, if the cat ever becomes refractory, the remainder of the teeth absolutely need to be extracted. And I would say that unless that cat is hunting its prey or defending its territory, it's already under anesthesia, you're already doing an extensive extraction procedure, it's probably best to get all the teeth out under that same anesthetic event, unless the owner is really gung-ho on preserving those canine and incisor teeth. I just think that I see more cases where that fails than where it's successful. Although I will say there are some dentists who will potentially start with that in very select cases.
All right. Our next question comes from Dr. Begun. With extraction of deciduous teeth, would damage to formation of adult teeth be a consideration?
Absolutely. Yeah. So that's something that if you don't have dental x-rays and you don't know where those permanent tooth buds are sitting, you may want to be a little cautious with that. You need to be very careful where you're putting your elevator. Oftentimes in those teeth, in fact, I don't even use an elevator. I actually use the backside of a scalpel as my elevator or luxator to try to get them out. I think that it causes a little bit less blunt trauma to the very soft developing tooth bud, but a complication of removing deciduous canine teeth is always, if there's unerupted teeth in the area, is you can cause tooth death or pulpitis to the developing tooth. That's something the owner has to be aware of. I would say in cautious hands, that is unlikely, but certainly if you're not super experienced with that, it's certainly something you should consider before starting that. Yep.
Would crown amputation of deciduous teeth be an option?
I would not move forward with crown amputation. They do have, deciduous teeth have the same structure as adult teeth. So there is a vital pulp central portion of those teeth and nerves. So if you're talking about crown amputation and vital pulp therapy, I don't think that if I was putting the patient under anesthesia to be doing a procedure on them, I would absolutely be extracting those teeth, because I don't really care about preserving the vitality of deciduous teeth that are going to be gone in a month or two anyway. And that is a little bit more of a sensitive procedure to do. So if there's a failure in vital pulp, which is a possibility, it can be a relatively catastrophic failure in those teeth. And so infection in that tooth root of the deciduous tooth is absolutely going to cause tooth death to the permanent tooth bud. So extraction of the deciduous teeth is what we recommend. We would never recommend doing a crown reduction or vital pulp therapy in deciduous teeth.
Okay. We have a question from Dr. Enners. With root resorption in dogs, how important is it to get the entire root versus leaving root if there's no obvious periodontal ligament seen on rats?
Yeah, that's a good question. And I think it's a similar thought process to cats. So what I say in cats is, if you cannot discern a true periodontal ligament, if there's no actual periapical disease, so you don't see lucency associated with that root system, and there's no pulp left in the center portion that could potentially become diseased, the likelihood is you're not going to need to remove that root. My goal in dogs is to get the root out in its entirety, because I think that more often on dental radiographs in dogs, that periodontal ligament could look a bit of a blurred line because of ankylosis and not true tooth resorption. And I think there's a higher chance that those teeth may abscess. I will certainly tell you in dogs who have generalized resorption, where the procedure would have to be prolonged significantly to get out some of these roots if they're very challenging. And I see none of those things. I don't see a periodontal ligament. I don't see a pulp, and I don't see any obvious periapical disease. The likelihood of them being a problem long-term is minimal. So I would say similar to cats with end-stage tooth resorption where you're doing a crown amputation.